Okay guys, now let's do some important MCQs. What is the oxygen carrying capacity of 18-year-old boy? Okay, with the hemoglobin of 14 grams per deciliter. See how to answer these kind of questions. Say here, this boy is having how much hemoglobin? 14 grams of hemoglobin per deciliter. Deciliter means how much? 100 ml. So it's very clear here that in 100 ml of blood, there is 14 grams of hemoglobin. So how to calculate the oxygen carrying capacity? 1 gram of hemoglobin, okay, 1 gram of hemoglobin will carry 1.34 ml of oxygen. Okay, 1 gram carries 1.34 ml of oxygen. Okay, this is a constant thing. Okay, but if you ask me, 1 molecule of hemoglobin will carry 4 molecules of oxygen. Okay, so here they are asking the oxygen carrying capacity. So now 14 into 1.34. Okay, 14 into 1.34. So how much it will be? It will be somewhere around 18 ml. Okay, 18 ml per deciliter. So this much is the oxygen carrying capacity. Okay, this is the oxygen carrying capacity in this boy. Okay, so how to calculate it? Take the hemoglobin concentration. Hemoglobin, how much hemoglobin is there? 14 grams into 1.34. If they say 14, you just multiply it with 14. If they say 15, multiply it with 15. Okay, something like that. Now, which of the following has maximum smooth muscles when compared to the wall thickness? Okay, maximum smooth muscles are present in terminal bronchioles. I have already taught you this in the rapid revision. Terminal bronchioles, generation number 16. It have the maximum amount of smooth muscle. Okay, it has the maximum amount of a smooth muscle. Next, RDS. RDS means what? Respiratory distress syndrome. So RDS is due to deficiency of, respiratory distress syndrome, also called as a hyaline membrane disease, is due to deficiency of surfactant. Surfactant is not there. Okay, is due to deficiency of surfactant. So instead of using the word surfactant here, they have given the major lipid. Okay, surfactant is a lipid, it's a lipoprotein, 90% it's a lipid. So they have given the composition of surfactant. You already know dipalmitoyl phosphatidylcholine, which is the major lipid. Okay, major lipid. So this is missing. Okay, in the respiratory distress syndrome, the surfactant is missing, or you can say the dipalmitoyl phosphatidylcholine, also called as lecithin. Okay, it's missing. If I ask you what is the minor lipid, the minor lipid in the surfactant is sphingomyelin. Don't forget about it. Okay, major lipid is lecithin. This is nothing but lecithin. Okay, guys, could you able to recollect that? What is the gold standard, 100% confirmatory to say that the fetal lungs are matured? Phosphatidylglycerol, don't even forget that. Okay, phosphatidylglycerol, presence of phosphatidylglycerol in the amniotic fluid, it's a confirmatory that the fetal lungs are matured. Done. Next, see how many questions were there on the surfactant. Respiratory distress syndrome is due to defect in which of the following cell? Okay, it's due to defect in which of the following cell? respiratory distress syndrome is due to deficiency of surfactant. Surfactant is produced by which cells? Type 2 pneumocytes. Okay, type 2 pneumocytes. So it's something problem with the type 2 pneumocytes. Okay. Adequate oxygen delivery to tissues occurs in which type of hypoxia? I have already explained to you. Okay, in all the types of hypoxia, the oxygen is not properly delivered to the tissues. But in one type of hypoxia, that is a histotoxic hypoxia, oxygen is delivered to the tissues, but tissues are unable to use the oxygen. Okay, so what happens in histotoxic hypoxia? I have already gave you. In histotoxic hypoxia, the problem is within the cell. What is that? See, histotoxic hypoxia is due to cyanide poisoning. Cyanide poisoning. So what this cyanide is going to do? Cyanide is going to inhibit electron transport chain complex number 4. When the electron transport chain is inhibited, okay, it's a cytochrome C oxidase. It's a cell which is unable to use the oxygen, but oxygen is properly being delivered to the tissues. But cells by themselves, they are unable to use the oxygen, okay, for the production of ATP. So in histotoxic hypoxia, the problem is at the level of cell. So oxygen, adequate amount of oxygen is being delivered to the tissues, there is no doubt. Okay, in hypoxic hypoxia, you know, the partial pressure of oxygen is decreased. Okay, in anemic hypoxia, problem is with the blood. Okay, the problem is with the hemoglobin. Either the quantity of hemoglobin is less or the quality of hemoglobin is defective. Okay, maybe methemoglobinemia or carbon monoxide poisoning. Okay, in stagnant hypoxia, what is the problem? In stagnant hypoxia, the problem is with the pump, the flow of the blood, maybe there is stasis because of the congestive heart failure. Okay, so that's the issue. The stagnant hypoxia, maybe the person is having shock, the flow of the blood is having the problem. Next, surfactant is produced by, okay, surfactant is produced by, direct single error question, type 2 pneumocytes. Okay, so these type 1 cells, are the major cells which are present, which are lining the alveolus. Okay, they are major cells. So through the type 1 cells there is a diffusion of gases. Okay, there is a diffusion of gases. And you know what are these basal cell and clara cells? The basal cell and clara cells are the stem cells in the conducting zone. Okay, stem cells in the conducting zone. But don't forget, these type 2 pneumocytes, they are not only producing the surfactant, they are also stem cells. Okay, they are also stem cells in a respiratory zone. They are also stem cells. Okay, next, look at this question. A preterm baby, okay, preterm baby who was delivered at 28 weeks, a preterm baby who was delivered at 28 weeks, developed respiratory distress syndrome. Okay, a baby is developing the respiratory distress syndrome. Which of the following is true regarding the surface tension and compliance? As simple as, like, you know, it is simple. This is a preterm delivery. Okay, preterm baby. You know, in preterm baby, what is not there? See, in preterm, enough amount of surfactant. Enough amount of surfactant is not there. So surfactant is less. When surfactant is not there, who increases? Surface tension increases. Surface tension in the lung increases. Now you tell me, whenever there is more surface tension is a collapsing force. It's a collapsing force. When surface tension is more, collapsing forces are more, recoiling forces are more. So it will be hard for you to stretch the lung. Okay, it will be hard for you to stretch the lung. So what happened to the compliance? Compliance is going to increase. Sorry, compliance is going to decrease. So you know that compliance and surface tension are inversely proportional. Okay, they are inversely proportional, right? So when surface tension increases, compliance decreases. It's hard for you to stretch the lung. And don't forget, what is the formula of compliance? Okay, just recollect. It is delta V by delta P. Volume change by pressure change. How much volume change for a given pressure? Okay, how much you give the pressure and how much volume is changed. That will tell you the compliance of the lungs. Next, a 30-year-old patient with a respiratory volume of 500 ml. What is exactly this respiratory volume? This is nothing but the tidal volume. Okay, this is nothing but tidal. A 30-year-old patient with a respiratory volume of 500 ml. The intrapleural pressure before the inspiration is -4 and -8 at the end of inspiration. Okay. The pulmonary compliance of the patient is, see, they are asking about the compliance. You know the compliance formula. What is the compliance formula? Compliance is equal to delta V by delta P. Just now I have explained you. Now, what is the volume change in this person? The volume change is 500 ml. So 500 ml divided by, and how much is the pressure change? See, to change this volume, how much is the pressure change that he have given? His pressure is changing from -4 to -8. Okay, -4 to -8 centimeter of water. So here delta P is 4. Okay, delta P, so it is moving from 4 to 8. Okay, 4 to 5, 5 to 6, 6 to 7, 7 to 8 change. Okay, there is a pressure change. So how much is this? 125 ml. So here the answer is 125 ml per centimeter of water. So this is the answer, which means for every 1 centimeter of water pressure, this much volume is changing. So this is the compliance of those lungs. Okay, his lungs are this much compliant, 125 ml change in the volume per every centimeter of water pressure. Now, look at this. By looking at this diagram, you can easily say this is a compliance curve. Okay, this is a compliance curve. Okay, see, how can I say this is a compliance curve? Here I am showing you -4, -5, -6. Okay, intrapleural pressure change. Intrapleural pressure is changing from -4 to -6 centimeter of water. Here I am talking about the centimeter of water. Okay, so here I am talking about delta P. So what exactly here I am talking about? Here I am talking about delta V. Delta V. So delta V by delta P will tell you about the compliance. Now what they are asking, it's a compliance curve. Okay, you already know it. This is the compliance of the lung during inspiration. This is the compliance of the lung during expiration. Okay. Now the difference is there. The difference in the trajectories. Okay, the difference in the trajectories between the inspiratory loop and the expiratory loop. Okay, is due to, okay, in this curve there is a difference between inspiration and expiration. There is a compliance difference. I have already told you this difference is called as what? Hysteresis. Okay, this difference is called as what? Hysteresis. And why there is this difference? Why there is this difference? This difference is due to change in the surfactant concentration and change in the surface tension. Both the surfactant concentration and surface tension, they changes during the inspiration and expiration. That's why there is a change in the compliance. Okay, so difference in the surfactant during inspiration and expiration. Yes, surfactant concentration changes. During inspiration, the surfactant concentration decreases, and during expiration, the surfactant concentration increases. Due to the change in the surfactant concentration, automatically the surface tension changes. Because of the change in the surfactant and surface tension, the compliance during inspiration and expiration will change. Okay, next, left shift in oxyhemoglobin association dissociation curve is seen with which of the following condition? See, they are talking about left shift. Left shift means high affinity state. High affinity means hemoglobin is tightly binding with the oxygen. Okay, hemoglobin is tightly binding with the oxygen. Hemoglobin is not releasing the oxygen. Hemoglobin tightly binds with the oxygen. Okay, so left shift is going to be seen in which condition? Okay, you already know the answer. Is alkalosis. Whenever the body temperature decreases, whenever your pH increases, your H plus concentration decreases, okay, your carbon dioxide level decreases, and fetal hemoglobin, okay, HbF, fetal hemoglobin, HbF. So in these conditions, okay, whenever these conditions are there in the body, the curve is going to shift towards left. Okay, this oxygen hemoglobin association dissociation curve is going to shift towards left. Okay, in which conditions I have gave the list in these conditions. So this is the answer. Increase in 2,3-DPG, 2,3-bisphosphoglycerate or 2,3-diphosphoglycerate, and acidosis, hypercarbia, more temperature, low pH, high proton concentration, okay, exercising conditions, all of them they will cause the right shift. Okay, all of them they will cause the right shift where hemoglobin is giving more oxygen to the tissues, more oxygen is getting delivered to the tissues. But wherever there is alkalosis, okay, wherever there is alkalosis, there is going to be left shift. Okay, so here I gave the list when you will be having right shift conditions and when you will be having left shift the conditions. Okay, next, prolonged inspiratory spasms. Okay, prolonged inspiratory spasms are seen in which type of breathing? Prolonged inspiratory spasms are called as apneustic breathing. It's called as what? Apneustic breathing. So when you will be having apneustic breathing, okay, when you will have this apneustic breathing, see, I want you to know, see, imagine this is the brainstem. Here is the pons, this is the pons, here is the medulla. Okay, the pons and medulla. Okay, look, there is a pneumotaxic center and here is the apneustic center. And here is the dorsal respiratory group, DRG, dorsal respiratory group, okay, PAD, pneumotaxic center, apneustic center and dorsal respiratory group. It's the apneustic center which activates the dorsal respiratory group. This dorsal respiratory group are going to produce the ramp signals so that there is continuous rise in the tidal volume. Okay, there is continuous rise in what? Tidal volume. Normally, this pneumotaxic center, it inhibits the apneustic center. Pneumotaxic center, what it will do? It inhibits the apneustic center. So apneustic center is inhibited, dorsal respiratory group will be inhibited. So there are no ramp signals and inspiration stops. That's okay, inspiration stops. But now imagine if the patient is having a lesion here at the mid-pontine region, at the mid of the pons, at the mid-pontine region, if there is a lesion, okay, in the mid-pontine region, if there is a lesion. Now, do you think the pneumotaxic center can inhibit the apneustic center? No. Now, what this apneustic center will do? The apneustic center continuously stimulate the dorsal respiratory group. The dorsal respiratory group is going to produce the ramp signals continuously, so that there will be prolonged inspiration. Inspiration is not going to stop. There will be more inspiration, more depth inspiration. Okay, there will be prolonged inspiration. So that prolonged inspiration is also called as apneustic spasms. Okay, or apneustic breathing. Okay, prolonged inspiratory spasms are called as apneustic breathing. Not only this, I want you to know a few more things. See, there is something called as a Biot's respiration. So what exactly is this Biot's respiration? Biot's respiration means, look, the patient is having deep inspiration, deep expiration, deep inspiration, deep expiration. So there is a period of hyperapnea. Okay, there is a period of hyperventilation, and there is no breathing. And again the patient is having hyperapnea, deep inspiration, deep expiration, and again there is no breathing, a period of apnea. So hyperapnea, apnea, hyperapnea, apnea. So such kind of respiratory pattern is called as Biot's breathing, and this Biot's breathing is going to be seen in damage to the central nervous system. Okay, there is a damage to the central nervous system. Okay, this is the point which I want you to know. Biot's respiration is going to be seen when the central nervous system is having damage. Next, what is Kusumal's breathing? Kusumal's breathing is continuous. There is no apnea in between. There is continuous deep inspiration, deep expiration, continuous hyperapnea, or you can say continuous hyperventilation. The patient is having continuous hyperventilation. So this Kusumal's breathing is going to be seen in diabetic ketoacidosis. That's the one important point which I want you to know. It is seen in many other conditions like ketosis, diabetic ketoacidosis, uremia, sepsis, salicylate poisoning, methanol poisoning, aldehydes. See, all these conditions are going to some way cause the acidosis in the body. Okay, these conditions are going to cause the acidosis in the body. See, whenever the patient is suffering with acidosis, the patient is going to do the hyperventilation. Okay, acidosis, the patient will do the hyperventilation to remove the carbon dioxide out of the body. Okay, carbon dioxide is the source of acid. So, if the patient is having acidosis, the H plus ions are going to combine with the HCO3 minus and forms the carbon dioxide. So, carbon dioxide goes out of the body. So, you are removing the H plus. Okay, you are converting the H plus into carbon dioxide, and carbon dioxide is going to go out of the body when you do the hyperventilation. Okay, so Kusumal's breathing is going to be seen with diabetic ketoacidosis, at least that one thing which I want you to know. Okay, and what is this Cheney-Stokes respiration? See, this pattern, Cheney-Stokes respiratory pattern, see, there is a gradual hyperapnea and hypoapnea, means gradual hyperapnea, hypoapnea, and a period of apnea. Again, hyperapnea, hypoapnea. Again, there is apnea. So, such kind of respiratory pattern is called as Cheney-Stokes breathing, and the Cheney-Stokes breathing is going to be seen during sleep and with certain kind of drugs. Okay, respiratory depression, like hypoperfusion to the brain. So, in that conditions. But mainly I want you to know this patterns, images. Continuous hyperapnea is going to be seen in Kusumal's breathing, and next hyperapnea, hypoapnea, apnea, hyperapnea, hypoapnea, apnea. That's going to be Cheney-Stokes. And Biot's. What is Biot's? Hyperventilation, apnea. Hyperventilation, apnea. That's a Biot's. Okay. Next, see, identify the marked area. Okay, identify the marked area in the given spirometry graph. You already know this. You already know this. So look at here, guys. So this is the marked area. Okay. So first of all, tell me what is this area which I am showing you. This area is your tidal volume. This is your tidal volume. Means 500 is going in, 500 is coming out. 500 is going in, 500 is coming out. So this area, I am talking about the tidal volume, the amount of air that goes into your lungs and it comes out of your lungs. Goes in, comes out. Okay, with a quiet breathing. So that's called as your tidal volume. But if I ask you, can you do some extra inspiration? Can you take some extra air into your lungs? Yes, of course, possible. So after taking the normal 500 ml, you can take some extra air into your lungs. How much? You can take almost 3000 ml extra air into your lungs. This is called as inspiratory reserve volume. So this area of the graph, again you can take it back. So this area is called as the inspiratory reserve volume, the top. Okay, again tidal volume, this is the tidal volume. But if I ask you, you can take some extra air out of your lungs. You can take some extra air out of your lungs. So this is that area. So here is how much, you know the value, 1200 ml. This is called as expiratory reserve volume. Okay, expiratory reserve volume. And whatever you do, some air will always present in your lungs. It will never come out. Okay, even after forceful expiration, some air will still present in your lungs. It will never come out. So what is this? Residual volume. Now you tell me. So this is the area that I have highlighted here. This area I have highlighted. Okay, this is the area that I have highlighted. This includes two boxes, this box as well as this box. So tell me, so this area, it is covering expiratory reserve volume and residual volume. So what is this? This is functional residual capacity. So what is functional residual capacity? Look, after quiet expiration, after normal expiration, inspiration, expiration. After normal expiration, how much air is present in your lungs? After doing the normal expiration, how much air is present in your lungs? That is functional residual capacity. Okay, so here the marked area is the functional residual capacity. Resting lung operates at when you are at rest, not inspiring, not expiring. Inspiration, expiration completed, you are at rest. How much air is there in your lungs? Functional residual capacity. Okay, functional residual capacity, tell me, it's a sum of expiratory reserve volume plus residual volume. If you add it, it will be somewhere around 2500 ml. Next, V by Q is infinity in which conditions? I have told you, V by Q is infinity in which condition? It's going to be infinity in pulmonary embolism. One condition, pulmonary embolism. Not only in pulmonary embolism, it is also infinity in anatomical dead space. In anatomical dead space, ventilation is good. Ventilation is good. But what about the perfusion? Perfusion becomes zero. Okay, V by Q, ventilation by perfusion. Ventilation is good. For example, let's take any number. Let's say, for example, ventilation is good. 4 liters, let's say, for understanding. But perfusion is what? There is no perfusion. Okay, the blood supply is not there. That's why there is no gases exchange. So, if you divide any number with 0, that will be definitely infinity. That will be definitely infinity. So, it's equal to dead space. Okay, V by Q is infinity means we are talking about dead space. Okay. Next, V by Q infinity means, you tell me. Already I have discussed V by Q is infinity in which conditions? Pulmonary embolism. Okay, for example, let me draw it for you so that you will have a better understanding. Here is the lung, here is the alveoli, here is the pulmonary capillary. Now you tell me what exactly is happening. You are having a embolus here. You are having a embolus, pulmonary embolism. You tell me, in this condition, ventilation is good. There is no problem in the ventilation. Air is coming. But what is getting affected? What is getting affected here is the perfusion is getting affected. The blood is not coming. The venous blood is not coming to this area. So perfusion problem. Ventilation is okay, but perfusion problem. Blood is not coming. If the blood is not coming means, will gases exchange occurs? Will gases exchange occurs? Tell me. So the hemoglobin have to come to that area. The blood have to come to that area for the purpose of gases exchange. Now when the blood is not coming there, no gases exchange. More blood will come means more exchange. Less blood will come means less exchange. No blood will come means no exchange. So V by Q infinity, it means no exchange of oxygen and carbon dioxide. Just remember. Okay, there is no exchange of gases. I have told you V by Q is infinity in two conditions. One is pulmonary embolism and anatomical dead space. You know already anatomical dead space is also called as conducting zone. In conducting zone, is there is any gases exchange? No gases exchange, no oxygen and carbon dioxide exchange. Don't forget, where we have studied ventilation by perfusion ratio 0. In which conditions ventilation perfusion ratio is going to be 0? It's going to be 0 in atelectasis, airway compression, or you can say foreign body obstruction. These three conditions. Okay, airway compression, foreign body obstruction, or atelectasis, ventilation by perfusion ratio is going to be 0. Ventilation perfusion ratio in the apex of the lung 3.2, in the base of the lung 0.6. What is the normal ventilation perfusion ratio? Ventilation perfusion ratio is 0.8. Don't forget. Next, a person develops headache and breathlessness. On trekking expedition, he is having breathlessness. It's very clear that he is having what? He is having hypoxia. When he is trekking to high altitudes, the partial pressure of oxygen is going to decrease. When the partial pressure of oxygen is decreasing means he is going to suffer with hypoxia. Okay. So following a rapid ascent of 3000 meters, okay, above the sea level, which of the following is not used in the treatment of the above condition? Say, which of the following? Immediate descent you have to do. Administration of oxygen, hyperbaric oxygen is given. Acetazolamide is given for the mountain sickness. Actually, he is suffering with the mountain sickness. Okay. So acetazolamide you can give, because acetazolamide, what it will do? It will cause bicarbonate diuresis. Okay, it's going to cause the excretion of bicarbonates. why we require the bicarbonate excretion is because, see, when a person is going to the high altitudes, he is going to do the hyperventilation. He is going to do what? Hyperventilation. Why hyperventilation? See, in high altitudes, what happens? In high altitudes, the partial pressure of oxygen decreases. When the partial pressure of oxygen decreases means peripheral chemoreceptors are activated. When the peripheral chemoreceptors are activated in the aortic body, in the aortic arch and the carotid body, when the peripheral chemoreceptors are activated, the activation of this peripheral chemoreceptors is going to cause the hyperventilation. So whenever you do the hyperventilation, the person will develop respiratory alkalosis. Okay, respiratory alkalosis. So already the patient is having alkalosis. Okay, so to control this alkalosis, this acetazolamide will be given, and actually acetazolamide helps in the acclimatization process. Okay, acclimatization process. So acetazolamide is given in the acute mountain sickness. Okay, but not the IV digoxin. See, IV digoxin, what exactly it is? See, digoxin, it's a cardiac inotrope. Okay, cardiac inotrope. See, we don't want any cardiac inotropic action here. Already, when you go to the high altitudes, what happens is your heart rate actually increases, your cardiac output increases, your stroke volume increases, your BP increases in high altitudes. Okay, so we don't want any IV digoxin here. We don't want any cardiac inotropic activity. So this is not given. Okay, this is not given. So this is a except thing. Okay. I have told you acetazolamide, how it works. It works by inducing the bicarbonate diuresis. Now, next look at this acid-base question. Patient with arterial blood gas, pH of 7.24. Okay, let's write here pH 7.24. How much is the bicarbonate concentration? The bicarbonate concentration is HCO3 minus is 28. And what is the PCO2? The PCO2 here is 60. It's very clear. The PCO2 is increased. Okay, PCO2 is increased. So normally, what is the carbon dioxide? How much carbon dioxide will be there? So it will be somewhere around 40 to 45. Okay, the PCO2 value will be 40 to 45. How much is the bicarbonate value? Bicarbonate value is going to be between 22 to 26. Now in this condition, it's very clear that the PCO2, the partial pressure of carbon dioxide, the PCO2 levels are increased more. So definitely, the carbon dioxide is more, it is going to cause acidosis. Look here, already the patient is having 7.24. Normal pH is between 7.35 to 7.45. More than 7.45, that is called as alkalosis. Okay, alkalosis. 7.35, less than 7.35, a value less than 7.35, that's going to cause acidosis. You know it. So definitely our patient is having acidosis 7.24, it's less than 7.35, right? So definitely this patient is having acidosis. So what acidosis? Is it a respiratory acidosis or is it a metabolic acidosis? Respiratory problem or metabolic problem, kidney related problem? It's very clear here the PCO2 value is more. So whenever the PCO2 is increasing, so definitely you can say this is a respiratory acidosis. This patient is having respiratory acidosis. If there is any problem with the bicarbonate, then we can say that it's metabolic thing. Here the bicarbonate are little increased, the bicarbonates are little increased. Okay, it's just trying to compensate. Okay, so this is definitely respiratory acidosis condition. Which are the following neurons fire during forceful expiration? During the time of forceful expiration, I have told you, expiration is a passive process. Expiration is a passive process, but forceful expiration is active. You require two muscles, transverse abdominis and rectus abdominis muscle. And which group of neurons are going to helpful in this process? Ventral respiratory group, VRG. So ventral respiratory group are going to fire only during the forceful expiration. Okay. Next, which of the following ions are involved in the peripheral oxygen sensing chemoreceptors? See here, I am showing you. This is let's say this is a chemoreceptor, peripheral chemoreceptor. You know, peripheral chemoreceptors are present in the carotid body and aortic arch. Now look, whenever there is hypoxia, what happens? How they detect the hypoxia? You know, whenever there is hypoxia, the ATP production goes down. Okay, ATP production goes down. Now when ATP production is going down means, okay, ATP production is going down means this channels, potassium channels, they will close. These potassium channels will close. They are ATP sensitive potassium channels. Okay, what exactly are they? They are ATP sensitive potassium channels. Now what is happening? Whenever there is hypoxia, the ATP production decreases. Simple. When ATP production is decreased, these ATP sensitive potassium channels, they are all closed. So potassium will start to accumulate inside the cell. Because of the potassium accumulation, now potassium is accumulating inside the cell, so the cell will become depolarized. Okay, the cell will become what? Depolarized. Now the activation, the depolarization of the cells, now they are telling there is hypoxia, there is hypoxia, there is hypoxia. This information will be taken by this afferent fiber. The chemoafferent fiber, they will take this information to the central nervous system that there is hypoxia in the body, so that you will do the hyperventilation. So which channels are under the control? It's the potassium channels. So potassium channels, actually they are open, potassium is going out, but whenever there is hypoxia due to decreased ATP production, oxygen not there, no ATP means the ATP sensitive potassium channels close and the cell will become depolarized, and that will give the signal to the central nervous system. Okay, so with this all the important MCQs, one and all you need to know are completed. These are all the PYQs which will be helpful for your exam. With this, the entire rapid revision of respiratory is done. In the next video, we'll discuss the rapid revision of one more topic. Hope the video is helpful. Thank you.